So I'm going to talk about the approach to the child with poisoning in general from a pediatric emergency medicine perspective. As you know, it's one of the common presentations to wards as well as pediatric, like pediatric emergency department, especially if you take LRH. So it's a common presentation, and in children, poisoning is mostly accidental, whereas we see lots of adults coming with suicidal attempts, but in children it's mostly accidental. And the majority of poisonings are non-life-threatening. However, there can be events that can lead to severe complications as well as mortality as well. And deliberate poisoning and experimentation with illicit substances are now increasingly being seen compared to what we saw before. Why children are susceptible to poisoning? There is a bimodal presentation in children. One group are the group of young children who ingest the poison mostly unintentionally due to their exploratory or inquisitive behavior, and also due to the lack of sense of danger. Whereas the other group, mostly teenagers, they can ingest poisons both intentionally as well as unintentionally. And deliberate self-harm is increasingly seen in this age group. And also, there are many teenagers who tend to experiment with illicit substances and recreational drugs and then subsequently getting poisoned. So what's the general approach to any child with poisoning? Here, what I want to focus is, to give you the ability to manage a sick child, not the child who comes with no symptoms, who can be observed briefly and sent home. But there can be instances where children present with severe complicated presentations after severe poisoning. So the general approach can be understood based on this abbreviation, RRSI dead. So what do they stand for? So your first step should be to focus on giving resuscitation. And then after the child is stabilized, then it's important to perform a thorough risk assessment. And then to give supportive care, and then do investigations and do decontamination and enhanced elimination techniques, followed by antidotes, and then lastly to decide where you need to send the child to. So the initial approach can be understood as 3 stages. What we can do before the patient is brought to hospital, especially by the ambulance crew, and then what we can do at the emergency department, the ABCDE approach, and then the disposition for more definitive care. For example, dialysis or like administration of antidotes in an intensive care unit. So what can be done in a pre-hospital setting? So even in Sri Lanka, so when a child met with an accident or ingest a poison, parents might call for an ambulance service, and there is an opportunity to gain IV access and then to monitor the child during this time. And there are like little things which can be managed while the patient being transferred to the hospital. For example, administration of oxygen to a child having breathing difficulty or breathing respiratory depression, or a correction of hypoglycemia to a child who has ingested a poison which can cause hypoglycemia, such as salicylate or an oral hypoglycemic agent, or treatment of a seizure with benzodiazepine, and administration of naloxone, especially the children who accidentally overdose codeine or morphine, and treatment of broad complex tachycardia with sodium bicarbonate. And also there are like some studies done on the clinical efficacy of pre-hospital treatment with activated charcoal, but practically speaking, a little is expected with regard to this from the emergency medical services. So what can we do, as part of resuscitation? So as you all know, so airway takes priority. So where do we need to pay more attention to secure airway? So children who ingest corrosives, which can lead to airway burns, or plants such as plants containing calcium oxalate crystals, which again can lead to burns and corrosion of the oral mucosa, can have their airways at risk. So we have to follow the basics. So look, listen, feel, and then you can do simple maneuvers like jaw thrust, use of airway adjunct, and then you have to move into breathing after securing of airway. So what can you do for breathing? So attention to breathing is especially important in children who poison with agents such as CNS depressants, diazepam, or organophosphate poisoning, which can lead to cholinergic toxicrome, and a lot of secretions can plug and then result in breathing difficulty. So assess using respiratory rate, oxygen saturation, and then the work of breathing. And if the respiratory report is not satisfactory after correction of airway, you can give bag and mask ventilation until a more definitive airway such as intubation and ventilation is established. And then we move on to circulation. So some children might ingest poisons where you need to pay more attention on circulation. For example, drugs which cause hypotension, ingestion of agents such as beta blockers, calcium channel blockers, can lead to acute hypertensive shock. So your assessment should focus on assessing circulation, including heart rate, pulse volume, capillary filling time, blood pressure, and then resuscitation should be with 20 ml per kilo of crystalloid fluid boluses. And some agents, like if you take beta blocker overdose, child can be quite refractory to crystalloid fluid boluses alone, and your definitive treatment would be high dose insulin euglycemia therapy, which is used as a inotrope. And then use of inotropes and vasopressors should be done very carefully, and if you are in doubt, an opinion should be sought from the toxicological services. And some children might present with cardiac arrhythmias, for example, who ingest oleander or tricyclic antidepressants. So specific treatment with regard to correction of antiarrhythmics may be needed. And moving on to D, assessment of disability. Poisons such as CNS depressants or oral, overdose of oral hypoglycemics can lead to acute CNS depression. So in these children, attention should be focused more on assessment of disability using AVPU scale or Glasgow Coma scale, pupil size and reaction, and then you can assess and correct seizures, and if the blood sugars are deranged, then attention should be paid to correct hypoglycemia. And then E, exposure. So what we are mostly concerned in E is correction of temperatures. Some of the poisons can lead to hyperthermia. So what are these poisons? Hyperthermia in toxicology can happen due to agents that cause sympathomimetic overactivity or anticholinergic overactivity. So poisoning with sympathomimetic agents, so I will talk on what these agents are later on, or anticholinergic agents such as ingestion of athena, or certain toxicity syndromes like serotonin syndrome or salicylate. So children or young people who overdose these agents can present with hypothermia. So during the assessment of exposure stage, temperature should be taken, and if the child's temperatures are high, then child should be treated with active cooling using external and internal methods. And it is important to remember that use of paracetamol or antipyretics have no place in correcting these types of hypothermia induced by poisoning. So that is your ABCDE approach. So now let's move on to decontamination. So what we use commonly for decontamination is activated charcoal, and its recommended dose in children is 1 to 2 grams per kilogram, and it has to be given to have its best effects within 60 minutes of ingestion of the toxin. And however, depending on the situation, it can be administered up to 4 hours post ingestion, especially who present with life-threatening overdoses or present with slow release preparations. However, administration of activated charcoal can be difficult in children because it's quite unpalatable, and it's not happily accepted by most children because of its taste, and also it tends to be vomited out. So one of the techniques that you can use if you want to administer activated charcoal is to give it by mixing it either with yogurt or ice cream. That will increase its palatability as well as acceptance. It's important to understand that activated charcoal cannot be used to inhibit counter the overdose of ionized substances such as iron, lead, mercury, as well as acids and alkali. So we should not use activated charcoal in these settings. And also, use of activated charcoal is contraindicated if a child presents after ingestion of corrosives, or if you have a doubt whether the patient is having bowel obstruction or perforation, or where the patient is at high risk of aspiration following reduction in the level of consciousness. The other options, one option is gastric lavage. However, it's no longer routinely recommended. It has only limited indications because there is no clinically significant benefit in most poisonings. And also it has the serious complications such as aspiration as well as electrolyte imbalances when administered without proper precautions. It has a role in instances where use of activated charcoal is not allowed. For example, if a child presents with iron overdose or mercury, lead poisoning acutely, so you can use gastric lavage to do a washout and then quickly remove those tablets. In history suggests, history says there were children treated with the syrup of ipecac, but it's no longer used in clinical practice or as a home remedies. So that is the decontamination. So there are other methods also. So once the child has taken an overdose, we have to use techniques to prevent the effect of that poison on the body. So one method is decontamination. So decontamination means we try to prevent the poison from getting absorbed from the gastrointestinal tract, because activated charcoal absorbs the poison onto that and then gets excreted. The other method where you can get rid of the poison is after the poison gets absorbed to the circulation. So here, toxin elimination means after the poison gets into circulation, we try to get rid of it, get it out, either excreting it through urine, or either trying to get it back to the GI tract and then facilitate the excretion in the GI tract. So multiple dose activated charcoal is one of the toxin elimination methods. It is used to absorb drugs which has significant enterohepatic circulation, which means even if the drug is absorbed, once it's secreted back to the GI tract through the bile duct, charcoal gets bound to that and then gets rid of it. So multiple dose activated charcoal is used in children who poison with oleander or digoxin, carbamazepine and phenobarbital. So all of these poisons, or all of these toxins do have this enterohepatic circulation property. So when administered, multiple dose activated charcoal when administered, even if the drug is initially gets absorbed, but because it's getting secreted back to GI tract, then MDAC helps removing the poison through the GI tract. And also multiple dose activated charcoal is useful in instances where the poison forms concretions or besovas inside the GI tract. one of the well-known drugs or poisons is the salicylate. So salicylate, especially slow-release preparations, slow-release aspirins, they are well known to form bezoars, and they remain in the GI tract for a longer time before subsequently getting absorbed. So when you use MDAC, these concretions or bezoars can get easily, you can get them removed without them being absorbed to the circulation. And another elimination technique is the urinary alkalinization. So here you try to get the poison out and then excrete it through urine. So for urine alkalinization, you need to use IV sodium bicarbonate, usually given as a bolus followed by an infusion. So this helps in eliminating drugs that are principally excreted through kidneys. For example, salicylate. So salicylate, it's a weak acid. So when you do the urine alkalinization, your urine becomes very alkali, and then this weak acid gets bound to that and then prevents it from passively diffusing back or reabsorbed through the tubules to the circulation. So in that way, urinary alkalization promotes elimination or excretion of salicylate through urine. And in this, for urine alkalinization to be successful, you have to keep the urine pH between 7.5 to 8.5, which is the alkaline pH, with administration of sufficient sodium bicarbonate. However, as you know, sodium bicarbonate has a lot of sodium as well as bicarbonate. It's important to do electrolytes and blood gases during the treatment. And whole bowel irrigation is another decontamination method. Here, you infuse polyethylene glycol electrolyte lavage solution into the stomach at high flow rates. So this is especially useful for the toxins where you cannot use activated charcoal. For example, iron or lithium, like you can do gastric lavage. If there is a significant, a large overdose, gastric lavage alone may not be successful. So you have to do whole bowel irrigation. And whole bowel irrigation decreases the enteric transit time, and also it suppresses the time the toxicant has with the GI mucosa, facilitating its excretion. And hemodialysis is one of the other well-known toxin elimination technique. Hemodialysis used where all these other measures either are not alone sufficient to reduce toxicity, or the patient presents with significant life-threatening toxicity, so that you can use hemodialysis to get rid of the poison. But you cannot do hemodialysis in all situations. It depends on the poison. So this poison should be a dialysable one for that to be for the procedure to be successful. So what are these qualities? The poison should have a small volume of distribution, and should have a smaller molecular size, small enough to go through the dialysate membrane, and it should be water soluble. Lipid soluble ones won't be eliminated through hemodialysis, and it should have low protein binding capacity. So the poisons or the toxins which have these qualities can be dialyzed. So examples include salicylates, lithium, thiophyllenes, and toxic alcohols. And another method is called charcoal hemoperfusion, which is rarely used in Sri Lanka. The method is similar to hemodialysis. However, the cartridge you use in charcoal hemoperfusion contains charcoal, not a dialysate. So charcoal uses adsorbent properties and remove the toxin through the adsorbing to the charcoal. So example poisons or toxins include theophylline, barbiturates, and carboxyphenes. If you can remember the previous slides, all these drugs can also be removed from multiple dose activated charcoal because they get absorbed to activated charcoal. So once you do ABCD approach and then institute decontamination and elimination, one of the most crucial steps then to perform is to do a risk assessment. So risk assessment tells you whether the child has taken a significant overdose or a trivial overdose. And also you can predict whether the child will go on to develop complications or not. And also you can decide where the child is going to end up, whether they can be discharged or whether they need to be admitted to ward or whether they need to go to intensive care unit. So it is defined as a distinct cognitive process through which the clinician attempts to predict the likely clinical course and potential complications for an individual patient. So there are 5 components. So you have to determine the agent or the drug. This may be difficult in children because most of the time children, they are not, they are not, they don't tell most of the time that they ingested drugs. And usually parents also do not suspect unless they become symptomatic. For example, parents might not recall, parents might not be concerned until they find a drowsy child who has ingested a sedative agent. So it can be difficult at times. So you need to decide on the agent and also then to decide on the dose. So similar to deciding on the agent, determining the dose can also be very difficult at times. And the time since ingestion. So this tells you, whether you have a time window to administer decontamination or antidotes. And then assessment of the current clinical status. So you have to take observations and also you have to specifically look for toxidromic features. And then finally the patient factors, which include comorbidities such as obesity or underlying liver or renal disease, and patient's weight. So what supportive care you can, in general, you can give to children who comes with poisoning. So you can give fluid therapy, and in some instances you can give antiemetics and analgesics, sedation. The children who struggles or who have agitation after poisoning, they can be sedated. And attention to glycemic control, catheterization, anti-decompression, temperature control, and assessment of the psychosocial status. So these are like general things, but I will go on to discuss individual supportive care when we talk about individual poisons. So what investigations can you do in general to a child with poisoning? So first line investigations, you can do electrolytes, blood urea, serum creatinine, blood glucose, liver functions, blood gases. But this doesn't mean that you have to do all these investigations for a given child, but these are the kind of investigations you can consider doing depending on the situation. And osmolar gap determination is helpful, especially if you see an unexplained high anion gap metabolic acidosis. And what about urinary toxicology screen? For example, determination of urinary sedative levels, morphine levels, benzodiazepine levels. They are not used in practice because they are not useful in the initial management and the results are not readily available. However, they may be performed for diagnostic purpose, to prove that someone has taken a sedative drug, for example, in sports medicine. So in that sense, they can be helpful, but in emergency situation, this test is not helpful. And you can do quantitative drug levels if available, but in Sri Lanka, most of the time, these quantitative drug levels are not available. So one of the common instances that are used is the paracetamol level following paracetamol poisoning. And the other substances where you can do a level include salicylate, iron, lithium, digoxin, theophylline, ethylene glycol, methanol, carboxyhemoglobin, methamoglobin, and levels of anticonvulsants in blood. And you can consider doing radiological investigations like plain abdominal radiographs, especially in children who ingest radio-opaque material like iron, lead, mercury, cocaine, calcium, or enteric coated agents which can appear radio-opaque. And doing an ECG is very important when children present with cardiotoxic agents like oleander and tricyclic antidepressant poisoning. And then the next step is the administration of antidotes. So antidotes are available only for like a limited number of poisons, not for everything, and they effectively neutralize the effects of the toxin as soon as possible to counteract toxicity. However, antidotes can have their own significant adverse effects. We have to be very careful in treating children with antidotes, and if doubt, always seek opinion from a toxicologist. So disposition, in most cases, children coming with poisoning require admission to ward for at least brief observation. If you are deciding to discharge from the emergency department, then you have to take thorough history and perform a thorough risk assessment to rule out the need for admission. And also, not only the medical factors, also consider the social circumstances, including the parental level of understanding and competence, and their ability to come back to emergency department if the child goes on to develop symptoms. And any suspicion of deliberate ingestion that indicates underlying psychiatric or psychosocial issues, or incompatible history suggesting possible non-accidental injury should prompt you to admit children for detailed evaluation of non-accidental injury.